హలో
సార్ చెప్పండి.
అమ్మాయి రెడీయా సింజు?
స్లైడ్స్ కనిపిస్తాయి.
కనిపిస్తున్నాయి. స్లైడ్ షోలో పెట్టు.
సార్ స్లైడ్ షోలోనే ఉంది
సార్. ఎనేబుల్ ఎడిటింగ్ క్లిక్ చేయండి సార్ పైన.
అది అయిపోయింది ఆల్రెడీ. స్లైడ్ ఫ్లోలోనే ఉంది ఇక్కడ అయితే. నాకు మళ్ళీ ఒకసారి చేయాలి. ఇప్పుడు ఓకేనా?
లేదు,
ఇంకా స్లైడ్ షో రావట్లా.
స్లైడ్ షో మోడ్లో రావట్లేదు. దాని మీద క్లిక్ చేస్తే
ఇప్పుడు సార్
ఇప్పుడు ఓకే. Will we start? Is
Yes.
ready?
Yes, sir. A very good morning to everyone today.
Introduce చేయొద్దా నిన్ను? హలో
సరే, అమ్మాయి కొత్త గాబర్లో చెప్పేసింది.
ఇంతలే. Okay, good morning all of you. Today Dr. Sinju, who is the DNB anesthesia and IDCCM candidate in Care Hospital, is going to talk on gastrointestinal bleed. Dr. M. Srinivas is going to be the moderator of this class. Dr. Srinivas will introduce I already introduced, but if some more is there, Dr. Srinivas will introduce her.
Okay,
Srinivas.
sir. Good morning, everyone. So, Dr. Sinju has recently joined Care Hospital for her IDCCM with a background of anesthesia, which she has completed from Hiranandani at Mumbai, and now she has joined recently. And this is her first presentation. So, hope we'll give you a good presentation this morning. Okay, this is over to Sindhu now.
A very good morning to everyone. My presentation is going to be on gastrointestinal bleed. So let me start with a case scenario. Here is a 45-year-old male who is chronic alcoholic, who was presented to ER with multiple episodes of vomiting and coffee ground color vomitus, which is copious in amounts. Patient has given a history of last intake of alcohol just 2 days ago, and past history, he has recurrent history of admissions in ICU with either with complaints of hematemesis or for ascitic tapping. On connecting to monitor, the vitals are pulse 120 per minute, BP 72 by 44 mmHg, SpO2 is 92% on room air. As you can make out the physical appearance, he has got bilateral pedal edema, which is extending over to the legs, and per abdomen wise, he's a distended abdomen with caput medusae, umbilical hernia, and gynecomastia. Patient conscious wise is drowsy, arousable, intermittently obeying commands. This gastrointestinal bleed, I'll be covering in 3 subtopics, which includes upper GI bleed, lower GI bleed, and stress-related mucosal bleed. So I'm taking an anticipatory bail in advance because I know this is going to be a really long session. So starting with the bookish representation of the incidence and mortality of GI bleed. This is extracted from a gastroenteral journal which shows the annual incidence of upper GI bleed is 60 to 125 per lakh population, out of which 10 to 20% is accounted by variceal upper GI bleed, and rest 80 to 90% is accounted by non-variceal upper GI bleed. Out of this, 28 to 59% of the cases are attributed to peptic ulcer disease alone. The annual incidence of lower GI bleed is around 20 to 33 per lakh, whereas the mortality rate is concerned, upper GI bleed accounts for almost 5 to 12% of the mortality, and it is hardly less than 5% in case of lower GI bleed. Coming to etiology of upper GI bleed, from the figure we can make out, there is a lower end of the esophagus is exposed to is more common with esophageal ulcers or esophagitis, esophageal erosion. At the gastroesophageal junction, if you find any tear, it is mostly due to Mallory-Weiss tear. And any kind of gastric carcinoma, it is more common over the greater curvature of the stomach. And similarly, over the lesser curvature of the stomach, peptic ulcer is very much common. So is it in the first part of the duodenum. And vascular malformations, which consist of Dulophy's lesion, angiodysplasia, telangiectasia. This is also common in duodenum as well as the lower end of the stomach. And a patient presenting with history of aortic graft surgery is known to have aortoenteric fistula. Other than this, if the bleeding occurs into the biliary tract, it is called as hemobilia. And if the bleeding occurs into the pancreatic duct, it's called as hemosuccus, which is the other findings of the upper GI bleeding. So when a patient presents to ER, how to triage the patients, which patients are to be admitted in ICU, which would go into ward, and in which cases we have to conduct an urgent endoscopy. So the criteria is based upon the patient's presentation. If there is hypotension, patient is hemodynamically unstable, and in case the patient after NG tube lavage wash with normal saline, still there is persistent bloody aspirate coming, and on presentation itself, hematocrit is less than 25% in a patient with coronary artery disease, or less than 20% in a normal patient without any comorbids, or the hematocrit rise is inadequate despite blood transfusion, or patient has presented with multiple systemic complications like stroke or myocardial infarction. So such cases would go into ICU. Patients who are hemodynamically stable after fluid resuscitation, or at presentation has an hematocrit of say more than 30%, or the fall in hematocrit is less than 5%, or say the hematocrit is more than 25% in a patient with CAD, or more than 20% in a normal patient without any comorbids. And with all non-variceal upper GI bleeds, or patients without any systemic complications, these would go into ward. So all cases of variceal bleed and cases without any without adequate rise in hematocrit after blood transfusion, and patients presenting with hemodynamic instability, all would require emergent endoscopy. So there is this scale which is called as Glasgow Blackboard score, based upon the blood urine nitrogen, hemoglobin in men and women, and systolic blood pressure and pulse, and based upon whether there is any hepatic disease or cardiac failure, and symptoms like melena and syncope. We can score the patient according to this, and this score is taken pre-endoscopically, which helps in judging whether the patient requires any endoscopic intervention or not. And it also helps in predicting mortality to some extent. If the score is 0, we can say it is at low risk, and patient can be treated on OPD basis alone. Second score is complete Rockall score for upper GI bleed. This score is based upon age, presentation of shock, any coexisting illness like coronary artery disease, renal failure, hepatic failure, and endoscopic findings like peptic ulcer, erosive disease, or esophagitis, and the stigmata of recent bleeding, like active bleeding or visible vessel or any adherent clot. Based upon this, even the patient can be taken up for endoscopy, but the post-endoscopic Rockall score is more significant in predicting mortality as well as length of stay in the hospital. But over and above both these scores, the AIM 65 scores helps in predicting mortality and length of stay and rebleed. AIM 65 takes into consideration the albumin of the patient, which is less than 3 gram per deciliter, INR more than 1.5, the mental status of the patient, systolic BP if it is less than 90, and the age if it is more than 65. So considering the above case scenario, let us say the patient has presented with hematemesis, melena, or maroon colored stools, or associated with other complications like chest pain or abdominal pain. These are the common presenting symptoms in a patient. The signs could be tachycardia, tachypnea, resting hypotension in a patient who was normotensive or hypertensive previously, orthostatic hypotension, that is a fall in BP more than 15 mmHg and a rise in heart rate more than 20 beats per minute, dyspnea on exertion, oliguria, collapse, neck veins. These are the signs which are indicative of massive GI bleed, and it accounts for almost more than 10 to 20% of the blood loss in the total circulating volume. If it is less than 10%, then it is classified as minor GI bleed. Now coming to initial management of upper GI bleed, always go with this algorithm that would be very helpful to categorize the patient and go ahead with the management. First step is resuscitation. Resuscitation, as far as the clinician is concerned, ABC, that is airway, breathing, and circulation. Secure 2 large bore IV cannulas, give oxygen by nasal prongs, start IV fluid resuscitation with ringer lactate or normal saline. Send blood for blood typing, cross-matching, CBC, complete metabolic profile, a coagulation profile. And if the patient is bleeding profusely, we can even initiate a emergent massive blood transfusion protocol as per the hospital criteria. Then secondly, control the factors which are propagating bleeding. Mostly such patients, elderly patients, must be already on anticoagulants, thrombolytic agents, or antiplatelets, and may come with deranged PTINR or APTT. So in such cases, first of all, discontinue all these drugs and correct the parameters accordingly. If PTINR is deranged, let's go ahead with FFP transfusion. APTT, if it is deranged, go ahead with protamine infusion as soon as possible. Then identify the level of bleeding. If the patient is presented with complaints of melena or coffee ground vomitus, if there is hematemesis, then it mostly indicates upper GI bleed. If the patient has maroon colored stools or red stools on presentation, it is mostly lower GI bleed. But any patient, if at all has red stools, but is having hemodynamic compromise, always one has to rule out upper GI bleed on endoscopy. Now coming to the etiology of bleeding. If the patient already has cirrhosis, it is mostly variceal bleed. If the patient has hypotension followed by episode of bleeding, then it is mostly ischemic colitis. If the patient gives a history of polypectomy, then it is mostly post-polypectomy related bleeding. And if there is any history of aortic graft surgery, that means it is aortoenteric fistula mostly. With his patient giving history of radiation therapy, it is radiation-related enteritis, and a patient presenting with multiple episodes of vomiting, it is mostly malreveal stare. As far as the clinician is concerned, we have to think about ABC first. So the above case scenario, that the patient presents with copious amount of vomiting and collapses on presentation itself, then it's intubation wise, it's the most challenging case. So the challenges what we face is here, there is the laryngeal exposure is obscured due to blood and vomitus, and there is potential hemodynamic instability. The patient is at risk of aspiration and might have all be associated with multiple comorbidities. So the absolute indication for airway, protection of airway or securing ET tube would be low GCS, either due to hypotension or hepatic encephalopathy, patients who are at risk of aspiration, or if there is a risk of further duration. So, and in cases where there is upper GI endoscopy is expected in some time, or patients in which absolute tamponade is to be given using Blackboard Blackboard tube. So such cases would require endotracheal intubation beforehand itself. So how to go about this. The technique is always modified rapid sequence induction and intubation. Anticipate there would be hemodynamic instability and prevent it using blood transfusion, resuscitation with IV fluids and vasopressors. Give a head-up positioning, where use a head-up positioning at least 40-degree propped up, and give oxygenation, and this also prevents aspiration risk. Always, it's better to give a prokinetic to fasten gastric emptying, which is metoclopramide, but this metoclopramide has to be given at least 15 to 30 minutes prior, but we cannot wait until the airway is secured. So once you give it, go ahead with the procedure. So large bore NG tube is to be inserted, which would allow the gastric aspiration. And it is always better to go ahead with a double suction setup that is employed to assist on either side with the anchor suction. And this would help in facilitating your view during video laryngoscopy. Induction drugs, best drug is ketamine, which also provides vasoconstriction and keeps the BP up. It can be used at a dose of 1 to 2 mg per kg, along with some low dose sedatives. It's better to avoid midazolam in variceal bleed cases, and absolute neuromuscular blockade can be provided with rocuronium or succinylcholine. And it is better to avoid positive pressure ventilation because there is always a risk of gastric insufflation. If at all you want to go with slow gentle technique of 6 to 10 breaths per minute at pressure lesser than 15 centimeters of water. Video laryngoscopy, CMAC is the best. It also provides direct laryngoscopy access, but always keep a direct laryngoscope on the bedside. If CMAC is not available, then go ahead with direct laryngoscopy. Even one can consider meconium aspirator, which is attached to the ET tube, which would provide continuous suctioning.
Can you just speak a little louder?
Okay, sir. So where shall I start from? Again, from the beginning of the slide, sir? Hello?
Thank you.
Yes, sir. So one has to always go ahead with video laryngoscopy. The best is to go ahead with CMAC, or if CMAC also acts as a direct laryngoscope. And if one doesn't have CMAC in the institute available, always direct laryngoscope is best. Consider meconium aspirator, which is attached to the ET tube, which would provide continuous suctioning. And if the patient regurgitates while being intubated, then release the cricoid pressure, give Treadlenburg to the Treadlenburg position to the patient, and this will allow the contents to not contaminate the tracheal tract. There is this SALAD technique, that is suction-assisted laryngoscopy and airway decontamination technique, which has been described by Jim Ducanto, which helps in securing airway in such scenarios. So patients who are at risk of aspiration or has already developed aspiration may progress into pneumonitis, chemical pneumonitis, and which would later into progress and become aspiration pneumonia. And this has to be treated with ceftriaxone empirical therapy. So in the next slide, I'm describing about SALAD technique, that is suction-assisted laryngoscopy and airway decontamination. Here, you'd find there is this rigid suction catheter, which is held in an overhand technique using right hand, and it is inserted through the right corner of the mouth, and it is swept from right side to left side continuously. At the same time, all the contents are being suctioned out. Here they have used a video laryngoscope, but one can also go ahead with a normal direct laryngoscope itself. Once the rigid suction catheter is inserted completely into the hypopharynx and all the contents are being suctioned out, one can insert the direct laryngoscope from the right side of the mouth and sweep it along the surface of the tongue. And this rigid suction catheter should go below the laryngoscope, and it should be wedging upon the just above the esophagus itself, so that continuous suctioning can happen through the esophagus. And then this rigid suction catheter in a way also helps in doing the maneuver of laryngoscopy. At the same time provides better view and takes out all the contents out of the side and helps in intubation. So from the left side, from the right hand corner, one can insert the tube under vision. This technique was described by Jim Du Canto. Now coming to fluid resuscitation. So always and always secure 2 wide bore cannulas, 16 gauge each, and keep the patient NBM. Start with rapid infusion of isotonic crystalloid solution. While infusing, it's always better to go ahead with crystalloid solution, not colloids. Why? Because colloids are associated with increased risk of kidney injury, worsens coagulopathy, and there is always a risk of anaphylaxis. And the studies have shown there is no benefit of colloid transfusion over crystalloids. And in case the patient is still non-responsive to crystalloids, go ahead with resuscitation with blood and blood products. So in case there is a major hemorrhage, always initiate the major blood transfusion protocol with O negative blood. So blood, the PRBC transfusion, as per the Villanova et al. Study, it has advised that always the study has been conducted amongst 1,000 patients of upper GI bleed, and it has been divided equally. The primary outcome was 45-day all-cause mortality, and in the restrictive blood transfusion, they have kept a threshold of 7 gram per deciliter as a threshold for blood transfusion, whereas in empirical or liberal blood transfusion, they kept a threshold of 10 gram per deciliter. So the all-cause mortality in the restricted group is hardly 5% versus 9% in liberal transfusion group. And the restrictive transfusion group has also shown that there is reduction in rebleed, length of stay in the hospital, and requirement of rescue therapy. Next is platelets transfusion. Since cirrhotic patients are always coagulopathic as well as procoagulant, hence a threshold of 50,000 is to be kept for platelet transfusion, and that too when the patient is having ongoing bleeding. If the patient is not bleeding and still the platelet count is at around 50,000, then there is no requirement for empirical blood transfusion with platelets. Since massive blood transfusion or resuscitation would always leads to coagulopathy, and when we are talking about reversing the causes of bleeding, patients who are on aspirin, aspirin or clopidogrel, it can be reversed with desmopressin using 0.3 mics per kg, and those who are on warfarin can be reversed with vitamin K or prothrombin complex concentrate, which has shown to have better effects when compared to FFP transfusion. Mostly the patients are on newer oral anticoagulants like dabigatran, apixaban, rivaroxaban, in which cases we are blessed to have an antidote like idarizumab for dabigatran, but rivaroxaban and all doesn't come with any antidote. So in such cases, the best is to give time. Time provides enough. Time has to be provided according to their T halves. And since these are known to have shorter T halves, say 5 to 17 hours, 24 hours withdrawal of the drugs can itself decrease the concentration of these drugs from the blood. Otherwise, go ahead with hemodialysis in order to reduce the concentration of these drugs from the blood, or say go ahead with PCC or FFP transfusion if the bleeding has to be stopped urgently. Investigation, one has to go with the basic complete hemogram, coagulation profile, liver profile, renal profile, and endoscopy, colonoscopy, enteroscopy, CT, MRI, enterography based upon the etiology. Clinical indicators of acute upper GI bleed. When a patient comes, we have to, when a patient of upper GI bleed comes, we have to categorize them into variceal bleed, non-variceal bleed. The management would differ accordingly. Any patients of variceal bleed, one can identify if there is any history of varices or a chronic liver disease, if there is spider angiomata, ascites, splenomegaly, hepatic encephalopathy. All these features would clinch a diagnosis for a variceal bleed. Whereas in case of non-variceal bleed, the first criteria is absence of liver disease. If there is history of peptic ulcer disease or H. pylori infection, if there is history of retching, the use of NSAIDs or aspirin, and any patients of chronic kidney disease or valvular heart disease and telangiectasia. So based upon these clinical indicators, the first step of management would remain the same, that is initial resuscitation, A, B, C, airway, breathing and circulation. Then the pharmacological therapy would differ. In case of a variceal bleed, we have to start with octreotide infusion, that is 50 microgram octreotide and an infusion of 50 to 100 microgram per hour. Terlipressin has to be used. Terlipressin 1 mg every 6 hourly, and IV antibiotics is to be given in a case of variceal bleed in order to prevent spontaneous bacterial peritonitis. The best is ceftriaxone. And after this initial pharmacological therapy, one has to go ahead with endoscopy and endoscopic variceal ligation. If the patient is refractory to this, go ahead with transjugular intrahepatic photosystemic shunting tips, or surgery is required only in cases where there is splenic vein thrombosis, and in which case we have to go ahead with splenectomy. In case of non-variceal bleed, again, after basic resuscitation, ABC, or pharmacological treatment would require PPI infusion. That is, the best is pantoprazole of 80 mg IV bolus followed by 8 mg per hour infusion. And then we have to do endoscopy and find out what grade of ulcer it is. And following that, if that is also not possible, do angiographies, localize the site of bleeders, and go ahead with embolization. And surgery, what is recommended here is gastrectomy, partial gastrectomy, but this partial gastrectomy again comes with a high risk of mortality. Pharmacotherapy, I'm going to describe again, especially the proton pump inhibitors. As per the Annual Internal Medicine Journal in 2010, we know that proton pump inhibitors, it causes irreversible blockade of the H plus K plus ATPase and pump, and thereby it reduces gastric acid secretion and elevates the pH, gastric pH. Secondly, it helps in clot stabilization and prevents clot lysis, and also provides enough time for mucosal healing. So pre-endoscopically, proton pump inhibitors has been shown to help in OGD view. Hello.
I'm sorry.
Go ahead, Sinju.
Yes, sir. Pre-endoscopically, proton pump inhibitors are known to provide better ogiriscopy view and reduces the stigmata of recent bleeding if there is any active bleeding vessels or say visible bleeding vessels on endoscopy or adherent clot. But it doesn't increase any active bleeding, nor does it increase the need for surgery, decrease the need for surgery or mortality. So post-endoscopically, in non-variceal upper GI bleed, it prevents the risk of rebleed and reduces the need for surgery. But is there any role of proton pump inhibitors in variceal upper GI bleed? Yes. Post-endoscopy EVL banding, it is the prophylaxis of proton pump inhibitors is known to reduce the size of the post-EVL ulcers, as per the Sang, Her, Kang et al. Study. Now coming to octreotide infusion. Octreotide, it is nothing but a somatostatin analog which binds to the somatostatin receptors and by means of phospholipase C protein, it does initiate vasoconstriction of the arterioles of the splanchnic circulation and thereby reduces portal pressure. So again, it has an added advantage that it inhibits gastrin, motilin, secretin, and cholecystokinin, and thereby helps in vasoconstriction of the splanchnic vessels and helps in reducing the portal blood flow. So as per the Gaucher et al. Study in 2012, octreotide reduces the requirement of blood transfusion and endoscopic treatment, but it is not shown to have any reduction in rebleed or overall mortality. Coming to terlipressin, the use of terlipressin in variceal upper GI bleed, again, it causes vasoconstriction and thereby reduces portal pressure. That is the mechanism of action. The Annual Internal Medicine Care 2012 journal recommends that it has to be given as soon as possible, but at the max, it should be restricted to 3 days. Why? Because it comes up with very major side effects like mesenteric ischemia, myocardial infarction, and tissue necrosis. The fingers and all becomes almost dusky and may even start to fall off. So in order to counteract the side effects, NTG infusion can be initiated, but again, it comes with the comes at the compromise of hemodynamic stability. So now again, antibiotics, the use of antibiotics, Chavez Tapiat and et al. Has given a study, systematic review of more than 12 studies where he has studied over 1,000 cirrhotic patients of upper GI bleed, upper GI variceal bleed, in which he has recommended that in order to prevent the incidence of spontaneous bacterial peritonitis, it needs to be initiated within 7 days, which reduces the risk of infection, rebleed, and length of stay and mortality. Endoscopy. The timing of endoscopy is very important. It has to be always taken up after resuscitation and the patient is hemodynamically stable, or if the patient is oozing very badly. So pre-endoscopic NG tube insertion always has been a question of debate. Nasogastric tube insertion, though it provides high negative predictive value in diagnosis, that is after an insertion of the NG tube, if there is no bloody aspirate, then you can rule out upper GI bleed. But again, whether NG tube insertion is required during endoscopy or not, or whether it helps in improvement of vision during endoscopy or deployment of treatment, there is no such evidence. But unless and until there is any particulate matter in the vomiters or the patient is badly oozing, in such cases, definitely NG tube insertion is required. And the other thing is that it causes much of pain and discomfort. Instead of nasogastric tube insertion, the Academy of Emergency Medicine 2010 has done a comparison study between erythromycin versus the NG tube, where it has said that IV 250 mg of erythromycin given half an hour to 2 hours prior to endoscopy gives much improvement in the vision and is better tolerated by the patient. So in situations where one cannot control the source of bleeding, and in places where upper GI endoscopy is not available or radiological therapy is not possible, and in order to stabilize the patient, temporary control of variceal bleed can be given with the help of Sengstaken Blackboard tube. The technique is, first you have to definitely secure the airway of the patient and sedate the patient, keep him under soft restraints, give lavage with NG tube, remove the NG tube, and then introduce the lubricated tube until the gastric juice is aspirated through one of the lumens. So one can check it radiographically and then start filling the gastric lumen through that inflation line in 100 ml increments till 500 ml is reached. But sometimes you would find there is a drastic increase in the pressure, which needs to be continuously monitored using a manometer. So once there is a drastic increase in the pressure, you can suspect this lumen is inside the esophagus rather. So in which case we have to deflate the balloon again, insert it or advance it further, and then again start inflating it. Then clamp the air inlet, pull it back, and secure to traction device, which would provide good tamponade to the bleeding varices. And even for esophageal balloon inflation, one can inflate it to 30 to 45 millimeters of mercury using a manometer. And in order to prevent any pressure necrosis, it's better to deflate this every 5 minutes after 5 hours. Now coming to non-variceal bleed, that is peptic ulcer. There is this forest grade which classifies the ulcers according to the endoscopic findings, and accordingly categorizes it into class 1A, 1B, 2A, 2B, 2C, and 3. And this score is based upon, this also gives a comparative score of risk of rebleed and mortality. So 1A being active bleeding, 2A that is non-bleeding visible vessel and adherent clot, 2B and flat pigmented spot and clean ulcer base. So the maximum mortality risk is associated with active bleeding and non-bleeding visible vessels. And management of peptic ulcers, one has to start with the basic initial management, that is ABC, after securing the airway and making the patient hemodynamically stable. One has to go for further evaluation. One has to rule out H. pylori infection. If it is there, then H. pylori specific eradication therapy can be initiated, that is with clarithromycin, amoxicillin, or proton pump inhibitors. Or similarly, we can even go with LAP, or that is levofloxacin, amoxicillin, and penicillin. Likewise, if the patient comes with a history of chronic use of NSAIDs or aspirin, then discontinue the NSAID or replace it with lesser toxic ones, say coxibs, or in order to provide mucosal protection, misoprost can be given. And say in case of gastrinoma, it is better to evaluate further with serum gastrin levels, gastric output analysis, serum secretin levels, and go ahead with octreotide scan. And the management definitely would be surgical in such cases. Now, starting with lower GI bleed. Lower GI bleed, as per the traditional definition, we have always defined it as the bleeding distal to ligament of Treac. But the newer definition says it has classified it into small bowel bleed and lower GI bleed, which helps in accurately and promptly localizing the sites and helps in stratifying the management. So small bowel bleed is nothing but the blood loss between the ampulla of water and ileocecal wall, and lower GI bleed has classified it as bleeding distal to the ileocecal wall. The symptoms, any patient might present with scanty bright red colored stools or maroon colored stools, or with hemodynamic shock and collapse. Etiology of lower GI bleed, as one can make out from the diagram itself, in the small bowel, ischemic colitis, ischemic bowel disease, inflammatory bowel disease, infectious diseases, radiation-related enteritis, intussusception, Meckel's, diverticulum, any kind of gastric lymphoma or stromal tumors. Coming to the colonic sources of bleed, it can be any colonic carcinoma, angiodysplasia, Deulefoy's lesion, diverticulosis, inflammatory bowel disease, ulcerative colitis, radiation-related enteritis, hemorrhoids, rectal varices. So coming to the management of lower GI bleed. Lower GI bleed, when the patient comes with these symptoms of say fresh passage of clots or maroon colored stools, there is a massive bleed from the lower GI tract, one has to differentiate it with bloody diarrhea. So what are the causative organisms which can cause bloody diarrhea? The Escherichia coli O157H7 strain, CDAD, Clostridium difficile associated diarrhea, and in immunosuppressed patients, cytomegalovirus, and accordingly, the specific therapy needs to be initiated. So then one has to evaluate whether the patient is hemodynamically stable or not, and put in a tube and find whether there is any bloody aspiration from the NG tube. Or if the patient is presenting with history of aortoenteric graft surgery, then always suspect aortoenteric fistula, in which case surgical consult is to be given. So if the patient is hemodynamically unstable and is bleeding rapidly through the lower GI tract, always go ahead with angiography, localization of the site, and followed by embolization. If the patient is bleeding profusely but hemodynamically stable, in such case, but the patient is not able to tolerate the bowel preparation with PEG, such cases go ahead with tagged RBC scan and scintigraphy, wherein if that is positive, go ahead with angiography, localize the site of bleeding, and then embolize the specific vessel. If the patient is hemodynamically stable and is not bleeding profusely and can tolerate bowel preparation, in such cases, always go ahead with colonoscopy. If colonoscopy is negative, go ahead with capsule enteroscopy, push enteroscopy, double balloon enteroscopy, or CT or MRI enterography. So the specific therapy, once the bleeders are identified on angiography, would be either vasopressin infusion after specific catheterization of the bleeding vessel, or one can even inject methylene blue, which would help in localizing the site, and later on would help in surgical resection of the offending segment, and go ahead with embolization either way. Rest is that after stabilizing the patient, again monitor for rebleed, elective colonoscopy, elective capsule study, or MR or CT enterography on a later stage. So this is a pictorial depiction of video capsule endoscopy. Here there is a disposable camera, which is in the form of a pill. This is to be swallowed by a patient and on empty stomach, and there are some receptors which are kept on the around the waist of the patient, which receive signals when the pill cam is going down the GI tract. This pill cam would get excreted naturally through the GI tract, and all the pictures can be captured and downloaded to a computer, which can be read by a doctor. So this helps in this gives a picture of whatever abnormalities are there, but it doesn't give a real-time picture, and hence it is not good enough for executing any endoscopic therapy. So it is better to always go ahead with enteroscopy. Enteroscopy, we have spiral enteroscopy, push enteroscopy, or double balloon, single balloon enteroscopy system. In which case, this is a special endoscope which is longer than the usual endoscope. The usual endoscope is around 150 centimeter in length, whereas this enteroscope has a length of almost 200 to 250 centimeters. And this has this over tube. This comes with an over tube. You can see in the first picture. There are two specific balloons, and when one balloon would act as an anchor, and over which the other over tube can be pulled over. Likewise, when then endoscope would be advanced further, and again the over tube balloon would be inflated, and that would serve as an anchor at that point. And again, the enteroscope and can be advanced further. And you can see in the last images, the whole of intestine is getting plicated over the enteroscope, and in a way it is helping in deeper vision of the lumen of the GI tract, which is otherwise not accessible on a normal endoscope. So once you identify the site, the therapy which is to be executed would either be thermal therapy, injection therapy, mechanical therapy, or angiotherapy. So thermal therapy, you can give a heater probe, organ plasma coagulation, bipolar probe. Injection therapy, deliver epinephrine or sclerosing agents or hypertonic saline. Mechanical therapy would employ hemoclips or endoloops or band ligation. Angiotherapy would involve vasopressin or epinephrine, or ultimately embolization. Even the newer techniques have come up, which is being described on the slide, like over the scope clip, endoscopic suturing, mucosal ablation devices, fibrin glue injection, or hemostatic spray, or endoscopic USG angiotherapy. Now coming to the basic stress ulcer mucosal disease, which is a common entity in an ICU setup. This is a broad spectrum of pathological changes in the mucosa of the gastric lining, especially seen in critically ill patients as a result of physiological stress. So this physiological stress here, it is meant by the patients who are on prolonged mechanical ventilation, patients who are bleeding profusely, having coagulopathy, shock, patients with sepsis, multi-organ failure, patients having acute renal failure on renal replacement therapy, patients of post-transplant, acute on chronic hepatic failure, patients having multiple burns and multiple trauma, or patients having CNS injury and surgery. On such cases, the bleeding might even start in critical inpatients, and these bleed can be classified into occult bleed, overt bleed, clinically significant bleed. In which case occult bleed is where you cannot make out visibly, and hemoccult testing has to be done. Overt bleed is where it is visual, on visual inspection itself, it's very much evident. And in clinically significant bleed is the one which causes hypotension, tachycardia, and drop in hemoglobin of more than 2 grams per deciliter. The basic pathophysiology of a stress-related disease is that any patients who are on mechanical ventilation, all this physiological stress which I've described about, like mechanical ventilation, patients on of renal failure, burns, or severe sepsis, ultimately they give a picture of hypotension and shock and hypovolemia, which results in vasoconstriction and release of pro-inflammatory cytokines, and this would cause plankton and mucosal hypoperfusion. This would also decrease epithelial cell migration, decrease the bicarb excretion, and decrease mucosal blood flow. And the protective factors like prostaglandins, which are important regulating factors which initiate the repair of the cells when there is any injury to the gastric epithelial lining, that gets decreased profusely. And once the mucosal layer gets denuded, these are exposed through pepsin and H+ ions, which diffuses back and causes more injury to the gastric mucosa. The reactive oxygen species which are released causes direct cell toxic injury, and the nitric oxide production which are produced causes vasodilatation, because of which there is mucosal hyperemia and reperfusion injury. And all in all, these together causes stress-related mucosal disease. And therefore comes the role of stress ulcer prophylaxis. H2 receptor blockers, which are given to block the histamine, which in turn decreases the release of gastric acid into the lumen. And so are proton pump inhibitors. It causes irreversible blockade of H+ K+ ATPase pump and helps in decreasing the gastric acid release. Plus, the advantage of PPIs over H2 receptor antagonists is that it causes prolonged suppression and suppression at a greater degree. And therefore, but there are no data which suggest that PPIs are superior to H2 receptor antagonists. Likewise, there is the sucralfate, which is nothing but aluminium salt of sulfated sucrose, which does nothing but it provides a physical barrier against the denuded mucosa and helps in protecting it. Enteral nutrition is always advised, which provides a protective barrier against mucosal denudation. It in itself, like RT feeds in itself, are supposed to have alkaline pH, but more over and above that, it causes increased mucosal circulation, which is very much advantageous in a case of stress-related mucosal disease. Why? Because there is the basic pathology of stress-related mucosal disease itself, that is the decrease in the circulation and decrease in the release of bicarbonate. This itself is being catered at this point. So RT feeds are known to have a better effect when compared to the stress ulcer prophylaxis, which is given using PPIs and H2 receptor antagonists. But why we are against the stress ulcer prophylaxis? There are certain articles which has shown that the rampant use of H2 receptor antagonists and PPIs are associated with increased risk of nosocomial infection and also infection with CDAD because of the acid suppression. The gastric acid content itself, it provides a better protection against these pathogens, which is being suppressed with the help of these H2 receptor antagonists. So there are studies which is described on this table, which is supporting my statements. That is GI bleed, which is associated with increased length of stay and mortality in ICU as per the Cook et al. Study. H2 receptor antagonists are effective in reducing the clinically significant upper GI bleed as per the Cook et al. Study. And there are PPIs. PPIs are said to be equivalent in efficacy when compared to H2 receptor antagonists as per Lin et al. Study. Sucralfate and enteral feeding may provide some protection from bleeding, and acid suppression, especially with PPIs, are associated with CDAD and nosocomial infection, which I have already described. This is as per Baletta studies. And therefore, stress ulcer prophylaxis, though recommended, it should always be restricted to the cases which are known to cause physiological stress in patients admitted in critical care. And plus, it should be tapered off once the issues are resolved. Usually what we see is the stress ulcer prophylaxis continues from ICU till the patient is shifted to ward, and from there again patient, when he's being discharged, they still go ahead with this PPIs and H2 receptor antagonists and keep on taking it for a longer period of time, which can result into such nosocomial infections as per the Ballet et al. Study. So my conclusion is, first assess the patient with presenting signs and symptoms. Our initial focus always has to be A, B, C. Identify the source of bleeding, control the source of bleeding, and always prevention is better than cure. Thank you.
Very good presentation, Dr. Sinju. Srinivas. Hello, Srinivas.
Sir, చెప్పండి. Hello.
Start change. Yeah. Go ahead, Srinivas. Further.
Sir, మీరు స్టార్ట్ చేయండి ఫస్ట్ సార్. క్వశ్చన్స్ ఏమైనా ఉంటే any
Yeah,
doubts or any
one
questions
question to Sinju from me. Sinju, when do you go for emergency surgery?
Sir, can you repeat the question, sir? When to go for
When you
emergency?
will go for emergency surgery to control bleed?
Emergency surgery in case of splenic vein thrombosis, if it is seen in variceal bleed, that is splenectomy would be advised. Or the very urgent surgery is aortoenteric fistula. If it is being suspected, then one has to control the source of bleeding, identify and control.
Okay then. Any questions from Mohan Rao garu? Mohan Maharaj sir?
Sir, good morning,
Sir. Again, sir.
Questions, sir. Congratulations to Srinivas for evidence-based class. So, because even if you see, I just want to ask one question. What is the 1,000 patients first paper you have presented? When was it? Because you mentioned 10 years back regarding the pantocyte and infusion. Then you told about emergency department surgery around 2010. And you told everything is mentioned, but the first 1,000 cases has been studied and you are given the evidence. So what I'm really happy with is the time of presentation, the slides and the evidence and the paper backup support, everything is good. But only thing I will just maybe because in the real physical presentation, this is really nice. But when it comes to the most of us are using cell phone. Even if you can increase the slides number and reduce the content of the each slide, it may be more useful for ours. I'm not saying that for everybody. Maybe that's my personal feeling. And second thing is, as you said rightly, repetition of the procedure, HB guidelines, and the procedures. The procedures many of us does not know. We know the 3 contrast, we know the procedure, double balloon, and all these things. We won't do all these cases, all these procedures. And as you said rightly, the percentage of the bleeds of 80%, 20%, and outcomes of 90% of going contribute to the upper GI bleed. Everything is nice. The only thing is, as I'm not comfortable with your answer saying that what should tell when you go for a surgery. Because you said when you go for emergency surgery, that's what you asked, no? Question. Am I right?
Yeah.
Yeah. Is that answer is okay, sir?
Not
So,
any answer.
Sir.
Maybe the indications might be there, but not adequate. Some more indications are there for emergency surgery. Srinivas, can you elaborate on this? Hello.
Sir, refractory bleeding, already known case of CLD, refractory bleeding, who has already received multiple bandings, may not be benefit from repeated endoscopic or pharmacological therapies, or patients having a post banding ulcers who are not eligible for any further endoscopic treatment. All these patients are in addition to the surgical causes of this thing, bleeding.
And any cancer bleed, cancer, malignant.
Can obviously, but it might not. Immediate surgery, I don't say, because malignancy bleed, we can't do much by emergency surgery because it's an already expanded lesion or a metastatic lesion, or it is not an emergency procedure. It might be an elective procedure for a malignancy if the bleeding is controlled.
Any interventions, Srinivas? Means and can we involve the intervention radiologist? Hello.
Yes, sir. Yes, sir. She explained about intervention.
What type of interventions can we do, sir?
Sir, there is a procedure where you say BRTO, balloon occluded retrograde. That therapy, when you have occluded veins, it can be used in addition to tips, so that you are occluding the draining vessel and you are controlling the bleeding.
Yeah, that was actually Sinju very well presented you. So latest was actually earlier before the radiological the intervention radiologist we used to go for the surgery for devascularization of the entire stomach for recurrent varicose bleed, which is not controlled with endoscopic ligation. Now is that tips came. There are few types of rescue tips and preemptive tips, and as latestly as Srinivas has told that BRTO actually is playing a very important role in controlling the refractory varices. BRTO in BRTO also sometimes if we have found big institutions they are going in a percutaneous also. Because there are so many complications with the tips that BRTO is playing a crucial role nowadays in controlling the refractory varices.
Yeah, any questions from others? Madam, Rani Madam Lera.
ఇద్దరు మేడమ్స్ ఉన్నారు, అనురాధ మేడం ఉన్నారు, వరలక్ష్మి మేడం ఉంది, రాణి మేడం ఉంది.
Madams are not responding.
Hello.
Madam, చెప్పండి.
A nice presentation, Sinju. When you said about emergency surgery, like, uncontrolled peptic ulcer bleed, they have to go for emergency bleed. And also, like, as she said, when you suspect aortic aneurysm, sometimes it can cause fistula, aortoesophageal aortogastric fistula, it forms, then they have massive hematemesis. I did one case a few years back. So that case also, initially they thought it was peptic ulcer bleed, uncontrolled bleed, but when they opened, it happened to be fistula, aneurysm repair they had to do. So such cases, or when you think it's not varicose but uncontrolled bleed, then they may have to go for laparotomy immediately to control the bleeding and to save the patient. So I think that's all I want to add.
Nice presentation. A few things while presentation, I did not interrupt you. One thing is these patients, cirrhosis patients, will be on a beta blocker, most of the patients, for the secondary bleeding prevention. So usually tachycardia is not seen in these patients, even they are in shock. One. Second thing is, as you already mentioned that the Ryle tube will not tell us the amount of bleeding. Third thing is erythromycin you have mentioned. Instead of that, you can also give a metoclopramide. So there is no contraindication in that case. That's all.
That is the study, Anna. He told the study.
Huh?
He said was a study. They did erythromycin IV that clears the bleed, and followed by they did endoscopy.
Yes, sir. Basically, doing that is to clear visualization of the endoscopy. So erythromycin IV, we can also use a metoclopramide. So evidence is on metoclopramide also.
Okay. And another question: how will you differentiate mesenteric ischemia and ulcer bleeding?
Sir, మీ వాయిస్ బ్రేక్ అవుతుంది.
Mesenteric ischemia and stress or any bleed, ulcer bleed. How will you differentiate?
Bowel ischemia అంటున్నారా? ఏమంటున్నారు?
How will you differentiate bowel ischemia? Hello?
Yes, sir. Differentiate between peptic ulcer bleed and bowel ischemia. That's what you said,
Yeah,
sir?
Yes.
So bowel ischemia, this.
Hello.
Hello.
Cheppu.
So bowel ischemia always.
Go ahead.
Always there would be an episode of hypotension prior to the episode of bleeding, which would result in ischemic colitis. In case of bowel ischemia, peptic ulcer bleed, definitely the patient might give a history history of uh, prior intake of H. pylori eradication therapy. Likewise.
Srinivas? Hello?
సార్ సార్ వినిపిస్తుందా?
Any further clarification? చెప్పు.
Peptic ulcer bleed ఇప్పుడు bowel
Srinivas,
ischemia.
go ahead.
Sir, lactates.
See, lactate.
Yeah, correct. Lactate.
Sir, lactate might not be an indication. But
Lactate can increase both in
Sir,
bleeding
sir,
and
lactate is not an
Yeah,
indication.
both. Lactate is not the only indication, but lactate is also one indicator to see bowel ischemia.
No, sir.
Because
The
ischemia and
different.
perfusion, lactate is more increased in ischemic bowel.
Sir, ikkada presentation itself is different for bowel ischemia and
Presentation is totally different, sir.
different, sir.
టోటల్లీ డిఫరెంట్ డేవిడ్. లాక్టేట్ సెపరేట్ మెసిలిక్ ఆర్టరీ థ్రాంబోసిస్ దానికి ఎక్కువ పనికొస్తుంది అనుకుంటా కదా శ్రీనివాస్?
Sir, lactate, if the liver is okay, you might not see a very good increase in lactate even in bowel
Yeah.
ischemia.
యా ఇట్స్ అక్యూట్, ఇట్స్ నాట్ రియల్లీ క్రానిక్ కదా.
Exactly.
No, that is not only the indication to identify, but increasing lactate also is one of the indicator. Whereas in peptic ulcer, lactate will not rise.
Worsening acidosis, David. Acidosis gets worse very fast
madam.
in ischemia.
Yeah. Acidosis with increasing lactate levels.
Sir, ఏంటంటే
Shock.
ఎసిడోసిస్ అయినా లాక్టేట్ అయినా కానీ పెరిగేది బికాస్ ఆఫ్ పూర్ పర్ఫ్యూషన్. సో ఇఫ్ యూ హ్యావ్ బ్లీడింగ్ ఈజ్ వెరీ హై, then automatically this also will be elevated. So I think the presentation of GI bleed will be different, and the presentation symptoms nunchi kuda is different. Sir, one question is there in this.
Yeah.
Good morning. Can you please repeat the Valunier study regarding the targets for blood transfusion and kindly enlighten if targets holds good even today? Latest evidence. These targets probably.
ఏం టార్గెట్స్?
Sir?
ఏం టార్గెట్స్?
Question ఇక్కడ చూడండి.
Hemoglobin target.
Hemoglobin targets.
Probably.
Yes.
Hemoglobin target is 7 to 8. Always restrictive is better as per the new evidence. Restrictive is much better than the liberal therapy, liberal transfusion, and 7 to 8 is the target.
ఆల్వేస్ లెస్ ఇస్ మోర్ కదా.
Always less is more.
And also
Always
platelets kuda platelets 50,000.
Yes, 50.
And you can have INR also 1.5, less than 1.5.
Sir, David, sir, some more questions to the students.
అడగండి నేను డ్రైవింగ్ లో ఉన్నా.
Okay. So for all the students, so what is the role of pantoprazole in a case of cirrhotic disease presenting with a bleed? What I'm asking is about pre-endoscopy, not post-endoscopy.
Sir, same sir, in variceal bleed, even pantoprazole can be used, sir.
Why?
In recurrent variceal ulcer, there is a role of pantop infusion, sir.
Why? What is the reason?
Same sir, gastric usually PPA infusion to counteract the acidity of the gastric juice, sir. Same it can happen with there is a reflux and it increases the bleeding source. That's why recurrent ulcers can be better prevented with pan infusions.
What I am asking about pre-endoscopy, not post-endoscopy. Post-endoscopy, definitely yes, there is chances of rebleed and ulcer formation is decreased, right? But if the patient of CLD with a recurrent admissions with variceal bleed has come to you, so will you use pantoprazole and terlipressin or terlipressin alone?
I'll use Sir Pantoprazole also. Without knowing endoscopic, definitely there is variceal bleed. Then we can use, there can be peptic ulcer bleed also. That's why I will go with both, sir.
What is the incidence of peptic ulcer in case of CLD?
Number don't know, sir, percentage.
It is significant number. It is around 30%. So 30% of GI bleed in case of CLD can present with peptic ulcer. So obviously you have to use both pantoprazole and terlipressin.
Okay, sir.
The question is, what is the difference between octreotide and somatostatin?
Sinu, question repeat cheyi.
Octreotide mainly acts on the splanchnic circulation only, sir. Somatostatin can have systemic effects also.
The difference between somatostatin and octreotide, sir.
Srinivas.
Sir, చెప్పండి.
Sir, actually, Sinju has to enlighten that thing during this talk.
కొన్ని questions వదలాలి కదా సార్ discussion.
No. So no questions we have to ask to her. Actually, frankly speaking, upper GI bleeding is itself a one big topic, and she has to enlighten each and everything. PPA importance, vasopressin different type, octreotides, analogs. Just cheap.
True. అంటే మనకు ఉన్నది 45 minutes కాబట్టి we have to complete అన్నట్టు. Any student can answer. What is the difference between
questions? Time is over.
The difference between octreotide and somatostatin.
Put the study.
Sinju is there?
Yes, sir.
Yes, sir.
Yeah, please. Can you answer this?
No, sir. I'm actually not aware very specifically.
Sir, octreotide specifically.
చెప్పు రఘు.
Sir, octreotide acts more on splanchnic circulation, but somatostatin has systemic effects also, systemic vascular effects also.
No. Both are analogs. So doesn't make much difference in the action.
Sinju, one more question. What is the doses for the upper GI bleed for this PPIs?
It is pantoprazole 80 mg IV bolus stat followed by 8 mg per hour infusion for 72 hours.
Yeah. Did you mention during this one?
Yes, sir. I did.
70 dose also?
Yes, sir.
Okay, good. So what is the octreotide dose?
Sir, it is 50 microgram bolus followed by 50 to 100 microgram per hour.
Good. So after the tips, didn't read anything, any latest treatment regarding the upper GI hemorrhage?
Sir, I didn't get the question.
No. You put this treatment algorithm.
Yes, sir.
Which is the latest one, and you stopped the up to the this tips.
Yes, sir.
After the tips, anything can you done?
If it is still refractory, BRTO as a source.
Yeah.
Balloon retrograde, transvenous occlusion.
What are the advantages, disadvantages with the tips and BRTO? What are the main indications for tips? You should read, and you just wanted, because when we are studying during that time, these procedures are not there actually.
Yes,
sir, as David told that we used to go for surgeries only. Now tips came, different types of tips are there. So indication, contraindications, and also some centers they are doing tips plus BRTO, tips plus embolization and BRTO. So there is a comparative study also, tips and BRTO, tips plus embolization, BRTO, tips only and tips plus BRTO. These are the latest ones. You should know. That's what. Huh?
Yes, sir. Sure, sir.
But very well presentation. When you are going in depth, you should know presentation also. So,
Sure, sir. Thank you.
Presentation and time is over. We'll close the session and we will come for next Thursday. Thank you, Sindhu. Thank you all for your active presentation.
Thank you.